hepatotoxicity and by apoptosis. But one thing about it is that it affects the CD20, where T beta cells and memory cells are affected, but you still have plasma cell and stem cells there. So patients really are not exposed to infections if we are using the spares. It is not that common because they still have some plasma cells in their circulation. And we see that the radiographic mean endpoints at week 24, where we see that the erosion score has considerably decreased. But what happens in Pakistan? We have to look at our patients, treatment affordability, the cost, the risk of opportunistic infections, high prevalence of tuberculosis, and hepatitis C. So, with the relatively high prevalence rate of tuberculosis, we must be careful because it can lead to reactivation of latent tuberculosis with TNF agents, more so with infliximab than with etanercept. So if we decide to use that, we need proper evaluation and prior tuberculosis screening. It is vital before we start therapy to rule out any possibility of tuberculosis after the induction of anti-TNF therapies. Rituximab, which is less costly, costs like 1/3 of the price, acts mainly on B cells, unlike the anti-TNF, and therefore it does not carry a risk of reactivation of latent tuberculosis and other T-cell mediated opportunistic infections. So that is why we're using more rituximab here, because of the cost and because, of course, the prevalence of TB is a factor. But we must make sure that therapy with DMRs and biologics is guided by regular monitoring of disease activity and also monitoring adverse events or effects. And the disease activity monitoring which we are using is DAS28, easily measured. You do the tender joint score, you do the swollen joint score and the WAS, and you can calculate with a formula, and you can find out if your patient is less than 2.5, is in remission. We can achieve low disease activity status, which is less than 3.5. If it is greater than 5, then it's high disease activity. Now, what is the problem with what happens to our patients in Pakistan? What are the hurdles in intensive approach? I think what our physicians are doing is like wait and see approach, fear of toxicity. And physicians are using their clinical judgment rather than DAS scores and disease activity indices. Patient keh raha dard theek hai, okay, fine, theek hai. But you need a complete examination to assess the disease activity. And also, we have to educate the patient about their disease. Sometimes patients don't want to take medicine and they're on painkillers and prednisone and they seem to be doing fine. But you have to educate your patient. In fact, that's the first thing which you need to do. So there's inertia in clinical practice, or patients' non-compliance prevent us from reaching our targets. I think if we educate ourselves and educate our patients, we'll come across these hurdles. These EULAR guidelines, I was, impressed that it took such a long time to develop them because they were reviewing literature from 1962 to 2008. And finally, the recommendations were presented at the EULAR meeting in 2009. And very rightly so. I think this is what we have for the national guidelines with some modification, that you early DMR therapy, we escalate the dose to 20 to 25 milligrams per week within 3 months, induction of glucocorticoids, and if disease remission is achieved, yes, we continue with the medicine, and once the disease remission is sustained, we cut back on the medicine slowly, but if not, then we switch to another DMR. Again, could use glucocorticoids, but if the disease is still active, we have to go to a biologic. And while using biologics, the cost and the infection, which we have just talked about, which are endemic in an area, we have to be very careful. So what are the recommendations or contraindications for use of biologic and non-biologic agents, which are infectious infections, especially pneumonitis, malignancies like lymphoproliferative disorders, class 3, class 4 heart failure, hepatitis B, hepatitis C with class 3, class 4, creatinine clearance less than 30, MS, you do not use it, pregnancy, and if patients obviously are breastfeeding. We have to have a safety monitoring and risk surveillance going on. We should have our own registries, we should have complete data, and we should also look at the preventive immunization. So what are the challenges of physicians here? So main priority for primary healthcare provider is over here is to which the patient goes first is to recognize synovitis and make a diagnosis and initiate treatment as soon as possible. You don't have to have your laboratory test. Rheumatoid factor is negative, so probably doesn't have RA. I think early referral is needed if you have a diagnostic dilemma. But once you're going to start them on DMRs, you're not going to wait for years for them to go into remission because you only have 3 to 6 months window of opportunity that will make a huge difference in the long-term outcome. But if there is a persistent activity and lack of remission and you've not achieved it, I would really request you that you should refer this patient to the nearest rheumatologist. So successful treatment to limit joint damage and functional loss requires early diagnosis, aggressive therapy, comprehensive coordinated care from a lot of other healthcare providers in which we have physical therapists, rehabilitation specialists, social worker, our orthopedic colleagues, because you need to give them an early referral if you think the patient needs surgical intervention, and you must monitor them with blood tests and other monitoring activities. You must keep on educating the patient as well. Early referral to a rheumatologist and early referral by a rheumatologist to the orthopedic if you are seeing an impending tendon rupture or when you have osteoarthritis, which is, when they need joint replacements, and if you are suspecting a septic joint. So here is my another patient. I'm not going to take this lady out of this unless and until our healthcare becomes better for patients with rheumatoid arthritis. This young girl who used to come to our clinic is very happy, was treated, diagnosed early, aggressive therapy, got married, has 3 kids now. But look at this lady, she did not get what she got. So till we have all our patients getting care up to this standard, this slide will stay on here for a lifetime, I think, with me. This is my department, Sarah Walker, with Emmett behind, and Smile, I don't know where you are, and with our patients, I think in the next slide, and our rheumatology nurses. And this was our conference, and this is the recognition of FCPS as a subspecialty of rheumatology. And there we are. Thank you so much.